Minister Varadkar, Minister Lynch, very good to see you again. Ladies and gentlemen, I think the Minister, as you probably think we've been tic-tacking because some of the stuff that I want to say is very much echoes what he's had to say. I've called what I'm talking about tomorrow's healthcare, connecting the pieces, and I'll give a rationale for that. And this is the structure of what I'm going to talk. I'm going to talk a little bit about a process we started 2 years ago that we call Chatham House meetings. And I'd give one example in a bit of detail about primary care success from the US. And then the lessons we've learned from the Chatham House process. And then I have one slide about ancestors. I think we all need to lift our spirits a bit, so we'll talk about that. So we started a Chatham House process. This is the story of it. I can give you much more detail. Some of you here have been to some or all of the meetings. And it started 2 years ago when really a number of us were quite fed up with the negativity that seemed to swallow up health. And the thing about it is that when there is negativity out there, it has actually ongoing effect on St. John's Ward and on in the practices. It's quite baleful, and it does affect the interactions with patients. So we wanted to open up a process to gather lessons and ideas, and to hear about successes and mistakes, because we're much better at covering up mistakes, and that always gets us into more trouble. We had a group of stakeholders that I call the hands-up people whom we knew would put their hands up. We involved the Royal College of Physicians, the nurses, the RCSI, the ICGP, the medical unions, the IMO, the NAGP, and IBEC. And the idea was to start thinking about advanced healthcare to get us to the kind of place that the Minister's talking about. But this time to involve a wide variety of stakeholders, including clinicians. It's been very difficult to engage clinicians in this process and I'll explain a little bit about that. We drew on the experience of others, including the HSE, the VHI, the NAGP, the IMO, our friends in Carlow Kilkenny, Ronan Fawcett is here, I'm delighted to see that, IBEC and the Nevin Institute. And we engaged particularly with US innovators. We were able to get people from Kaiser, a Blueprint from Vermont, the Primary Care Patient-Centered Collaboration Centre, and they all came. It was quite amazing, really. They came and gave their time free. We thought, how are we going to afford these guys? They're getting on a bit. Well, they want first-class flights. They paid for their own flights to come and help us out. And the kind of themes that we discussed, and we can talk about these in more detail because I know time is short. One of the first questions that came up is, what would GPs do if we got $1 billion? Supposing we met a nice minister or a nice CEO from the HSE and said, there you are, there's $1 billion. We've a $500 million at the moment. And, would we just pay ourselves more? There's a good body of thought that would support that. Would we put on more services for patients? Or would we say, no, we don't want it. We've no ideas. And where will it come from? You can see our system is fairly sealed, really. There isn't, even though the graph is going up to 14 billion, there are lots of calls on it. So this was a very rich theme that we talked about. And then the other one was, it seems to be a national pastime. I'm sure Tony O'Brien is well used to hearing this, people giving out. We'll explain to Richard Corbridge what giving out is at the end of this, but it's a particularly Irish pastime where we give out about the HSE or the Department of Health. And it amuses me in general practice that I know a number of GPs with the strongest views about the HSE and the Department of Health, and the minority of their patients actually have anything to do with the Department of Health, the GMS, because they're majorly in private practice. 60% of citizens don't have access to general practice, although that is GMS general practice, although that is changing. And then something that emerged, which even though it's only, according to the minister's slide, it's only perhaps 1% of GDP, but it's a very important vector in our financing and provision of healthcare, is our insurers, by and large, fund secondary care. They haven't engaged with primary care, and they're a very important part of it because they have leverage. But they haven't done this. So we brought the insurers into the process, and they gave stout defences of why they were doing what they were doing. But at least they had to defend it, and I still don't believe their defences. And then one of our US experts told us about meeting a group of our colleagues in both management and clinicians. He said he met them for an hour, and for 58 minutes they discussed nothing but problems. And then, being American, he said, well, what are your solutions? And there was a silence for 2 minutes. So that isn't right in a system. And this kind of made the purpose of the Chatham House process, that here were people on the ground who were happy in the groove of giving out, but actually didn't feel that solutions came all that easily to them, or if they came to them, that they weren't actually going to be listened to or put into action. So it did leave us wondering if there are good ideas out there from people on the ground. Quite important, really, if we're talking about some bottom-up stuff, that we have to have people with ideas. And the other thing that came across loud and clear was this thing about leadership. There's a kind of self-effacing nature in medicine. It may not look at looking at the likes of myself and Roseanne, but there is a self-effacing where, tall poppies are rapidly mown down, and leadership is seen as something that perhaps is for politicians or for others. But we have a leadership deficit. And actually we discovered in clinical areas, leadership is an international problem. That a lot of our clinical leaders have either got out of the system, and that's why I'm very welcoming of the idea of clinicians in primary care, getting into primary care, into leadership positions. So the thing, of course, is leadership is not necessarily management. People often confuse that. Some good leaders that I know would make terrible managers. I wouldn't let them manage my own personal affairs, but they have the charisma to do it. And of course, some leaders are a nightmare for managers because their vision keeps getting in the way of management. And delivering good results, we saw very much needs collaboration. I'm old enough to remember that when we had good clinical leadership, and it often came from ward sisters and people with strong personalities, personality-based leadership, and of course that made a difference to patient care, made a very strong difference. Now that's been replaced, and they were able to get people to collaborate, often by diktat, of course. But now that we don't have that anymore, we do need different skills to put leadership into action. The other thing that we learned from our American colleagues was that incentives work. And I learned this when I was an NHS GP, and they brought in a sum of money for us to do minor surgery. And we were meant to do 15 minor surgeries in a year, but we could do them at any time in the year. And within 5 months, the budget was blown because GPs sucked up the minor surgery and were able to get on with it. And that was a crude example of incentives. Our immunizations are an example of incentives. I think we need more incentives. There is too much, particularly in the hospital sector, I think there is too much of, it's kind of, well, you're there forever. and it takes a lot to dislodge people. We need to change that. And IT, this came across time and time again. I was thinking on my way in this morning that probably the third most difficult job in Ireland must be Director of IT. Richard has gone, obviously, but trying to drive change in IT and getting the unique identifier in, I think, is a huge achievement, actually. I didn't think we'd be able to do that. And data analysis. This came across to us loud and clear that the United States, which had to invent primary care, has been able to make a case for it year by year because they've had data strong enough and data analytics strong enough to be able to show the politicians that change is happening, they're seeing more patients, outcomes are better. And one of the comments that came from one of our American speakers when I asked him about, why is it difficult to get us to change? Because the minister has outlined an agenda for change. Why is it difficult? And he said, I'm just leaving this with you. I'm not going to comment. He says, you're not in enough pain yet. Which was interesting. As providers, we weren't in enough pain to change. But we had very lively engagement throughout the whole thing. We learned in it that through the process, because we engaged clinicians in both primary and secondary care, that clinicians have a genuine feel for the patient, but not for the system. And this is hugely frustrating. I'm sure the managers here know precisely what I'm talking about. Clinicians don't have, and it's the way we're trained. It's a bit like moral theology. We're given the case, and then you work back. When we're given the case really drives us. But actually, the system is seen as frustrating us. And the BMJ ran a series some years ago saying, can managers and clinicians ever be friends? And I think friends is pushing it a bit. But at least we can have some kind of standoff where we respect what each other are doing. Staff, we discovered, were concerned with survival because innovation has personal risks. And it may be only the Joe Duffy show, but I mean, we have, as individuals, we can be picked off too easily. Lots of non-sustainable innovations. Pilot-itis came up several times as a problem. And the insurers not using considerable leverage. They have little expertise or feel for primary care. And we learned how to herd cats. One of our colleagues said to one of the American speakers, and you don't mess with these guys, they're quick on their feet. She said, we'll never get that going. She says, trying to get change going in Ireland is like trying to herd cats. And he says, you know how you herd cats? You move their food. And we thought of starting a move the food movement, but it goes back to incentives. Oh, that's not very good. This is one of our speakers at one of the conferences we had, which was from Vermont, where they have the blueprint for Vermont looks after 500,000 patients. They've got about 124 practices. And you can see the bottom line here. The costs are about €500-600 per annum per head cheaper than in the non-participating practices. So that's just on the cost front. This report from North Carolina came out last August, and this is an audited report on primary care, community care they call it, that's been going since 2003. They have comprehensive, coordinated, high-quality primary care. They had to put a community infrastructure in place, and their focus was on ED and inpatient use. And they put in place from day one advanced data analytics and they said it's to maximize our return on investment. It was a very uniquely American way of doing it. They were investing in IT and they wanted a return on it. So how did it go? They had an annual savings of $300 per patient, a 20% increase in doctor services. And this was interesting that the services increase. Now, it is a case if you build it, they will come. But these are services that they were able to document. They had a 25% inpatient reduction in inpatient admissions, 11% decline in prescriptions. There's now a phenomenon called deprescribing, which is, again, very important. It's a very important aspect of primary care that we deprescribe. And we do it informally with patients coming from the hospital. We stop their medications, but it's important that it's done in a systematic, evidence-based way. The readmissions are a real killer. They're a great marker of how well a system is doing, because it's very easy to close the ward on Friday and then the patient's back in on Monday. That isn't really very helpful to anybody. And they did have a reduced readmissions and inpatient for diabetes, but the only significant readmission reduction was in asthma. And interestingly, unlike other US data which I have, they showed no significant reduction in ED usage, which is interesting. Now, the other big thing that we learned, and this really is is the core message, really, is when I have here on your left-hand column what they had to build in the US. And by the way, US GDP has gone down from 22 to 16% spend on health. This is with the impact of the Affordable Care Act, with their move to primary care in many places. But they had to put in place the GP. They had to put in place the referral system. The referral system is crucial to controlling our costs. They monitor referrals so that if the referrals are inappropriate, they know about it. They have to put in place a community infrastructure for social care. That didn't come naturally to them. Monitoring prescribing, robust IT and analytics. But most of all, they told us they had to put trust in place. Because people say, I want to see the top man. I don't want to see some GP working out of a community health centre or whatever it is. So this kind of is a bit of PR and a bit of trust and doing it right. And then when you look at the Irish system here on your right-hand side, we have about 3,000 GPs who are now all well-trained, well-established referral system, but it's not monitored. They're just left lying there. Some of my colleagues refer easily, some don't refer easily enough, so there's a huge range, and each referral is very expensive. It's a very, very expensive process. We have a voluntary and community infrastructure. We have a lot of experience in monitoring prescribing. I get reports from the primary care reimbursement system on where I'm out of line with various medications. And the big missing piece for us, which the Minister has pointed out, and we feel it very much, because we can't make a case. If I go along to John Hennessy and say we need more money for this, that and the other, what's the evidence? We don't have it. We have the IT, we have it in place, but we don't have the tradition of counting, we don't have the tradition of measuring. In the US, they said this is to maximize a return on investment. And of course, unlike in the US, there is huge trust in the GP, and has remained so. So the question that came up is a tough one, really. What is enabling our inertia? Because inertia has to be enabled, really. We have an inertia. Well, fear and the economy. I think the last 5 years have been very difficult. Been very difficult for patients, have been very difficult for staff, have been very difficult politically, have been difficult for everybody. And the question is it possible to do the right thing at the right time and take the risk it mightn't work? I think that's hugely important. If people do the right thing at the right time, and if it doesn't work, can we support them? We've had tentative political, excluding our present system, political, managerial and clinical leadership. I had other words in there, but I thought I don't want to be too offensive. But it has been tentative. I think we would all agree with that. I think we've had too many pilots. We need to start thinking about if something works, then we scale it up. And we also need to start thinking about stopping stuff. There's stuff that's going on that needs to be stopped. Now, I don't know who's going to do that. I mean, there are places that should be stopped, and it's very difficult to do that. And I think we'll need some kind of independently moderated organization who will help us along that journey. And of course, the lack of integrated support systems. for data, clinical and finances is really very, very difficult for us. Now, this is what our Chatham House people would support. These are the ideas that have come up in no particular order. I think we have to incentivize places that will have IT systems that talk to each other. There is no reason that in my clinic in West Tala, where I've invested heavily in IT, that IT can't talk to the hospital I refer most to. And I think that has to be incentivized in some way or other, because incentives work. We need to move the food. And we need to give Richard Corbridge a lift and move the food towards IT for a period of time. With chronic disease management, I think we need bundled management where both GP and hospital implement management for chronic disease. And I think this has to include the insurers as well. I think this is very important, that both insurers and the state, even though the state is really the major payer for our healthcare, I think it's important that we get the insurers in as well. We need to focus on unplanned admissions and readmissions. And again, how do they do this in North Carolina? Greater use of electronic systems for GPs so that I know where I can get my orthopedic patients seen most quickly. Whether it's in Tala or whether it's in Kappa or wherever it is, that I can get them seen most quickly. And also for patients, that they can actually book in to see me so that we get IT. The minister can order his pizza, but certainly patients can't get on the IT system that I've invested heavily in and book and see when I've got a free appointment. Diagnostics remain the bane of our lives. It's a misery trying to practice reasonable medicine in Ireland as a GP. And I think we need to outsource our radiology. And this came very strongly. Radiologists have a feel for business. They have a nose for it. But they're pressurized. While the radiology department is located in the hospital, they can too easily be pressurized into putting the hospital patients ahead of mine. That is never going to work while they're on the same premises. I think we have to incentivize radiology outside the hospital centre. I think there has to be some way of doing that. Intra-GP referrals. So this is going on now. We have a lot of GPs with particular expertise. The rivalry between GPs is not what it used to be. I think the co-ops have given us a huge lessening of rivalry between us. It doesn't mean competition is any less, but rivalry is less. And I do think there is now opportunities for us to use the specialized skills that some GPs have, be it minor surgery, be it the care of chronic disease or whatever. Prescribing. We did wonderful work here when prescribing. We had indicative drug saving scheme. I think we need to, again, it will give us a bit of a lift to put that in place again. And I think with this phenomenon that has started of deprescribing, I think there are opportunities for that. And I think most of all, we need to transfer a proportion of the hospital budget. There's loads of stuff going on there that isn't working. And it needs to be a proportion of the budget, even if it's 1%, transferred out to the community. And I think that's clearly going to happen. The minister's slides there, it's unsustainable having those kind of overruns in year on year. And just to accept those overruns, we can't do that in a modern economy. And I think we have to, we know where it can be done cheaper. The US stuff shows us where it can be done cheaper. And I think that's got to be, and this came across strongly from our Chatham House meetings, where we now have over 120 subscribers. So we've moved on. Chatham House, the system for Chatham House, and those of you who keep an eye on northern politics will know that a lot of progress was made using the Chatham House rule, where you discuss things but you don't attribute them to an individual. Well, we've moved on from that now. and we're setting up tomorrow's care, and it's called Connecting the Pieces. And we're using Connecting the Pieces very advisedly because the pieces are there. Remember that slide from the US, comparing the US and our system. But it's like having the jigsaw pieces. They're not actually working together. And sometimes we even trample over the pieces. So our strong argument, our intellectual argument, is that we need to work at connecting the pieces. We have the pieces. There are many systems would give the right teeth to have the pieces that we have, but we haven't connected them. And if you're interested in hearing more about it, and more about tomorrow's care, and as individuals, I know as perhaps in organizations you can't do that, but if you're interested, I would be delighted if you would email Deirdre Handy, my long-term standing colleague, dhandy@tcd.ie. And my final slide, I told you, is about ancestors. And this is a very interesting man called Jonas Salk, who developed the polio vaccine. And he was married twice, and this is real, perhaps, anyway, I'll say it. His first wife was the only woman, apparently, that declined Picasso's advances. So he knew how to command a bit of loyalty. But anyway, he said, the greatest obligation is to be a good ancestor. And this is my granddaughter, and she won't get polio because of Salk, and she's a very proud owner of a medical card, again because of somebody being a good ancestor. So thank you all very much.